All right. Alex Tang is the clinical director for the Chinese American Independent Practitioner Association. After 5 years serving critically ill and underprivileged patients as a trauma and critical care physician assistant to working as a first assistant PA in the Department of Neurosurgery, he now leads the care coordination team and manages the home assessment program for Kaipa. Thank you so much for your time today, Alex.
Thank you for having me.
So to start, could you tell me a little bit more about yourself and your life?
Again, you mentioned already, I'm a physician assistant. I was born in Hong Kong, came here when I was like literally a month old. And Growing up, I actually wanted to become an architect and not really a physician assistant. Somehow in the mix, I think through some life journeys, had my grandma passed away, and so like I've had a lot of experience in terms of healthcare wise, in terms exposure during the early stages of my life, and so somehow that changed my mindset and going from building stuff to taking care of patients, taking care of people, and somehow in the midst of it, which I think I found myself to be very fortunate and lucky, I found the PA profession. I think it's because, and at that time, no one knew what a physician assistant was, and so I was fortunate enough to find a PA at one of the practice that I volunteer in, and he's been a mentor. I've always talked about him. Steve Yao is one of my earliest mentors as a PA, and I've shadowed him when he was in oncology, and then at the same time when he was in cardiothoracic surgery in Bellevue. And so kind of like he was one of the reasons why I went towards that PA route, learning the flexibility and the uniqueness of the career, of the profession. And it's something that I didn't have to commit myself to just like one field. I can be very well rounded. Therefore, after graduating from PA school, I became a trauma PA. I did that for 5 years. Learned from one of the best surgeons, like actually a lot of really renowned surgeons in the field. I can't say one best surgeon, renowned surgeons in the field. And afterwards decided to take my talent to NYU neurosurgery because I wanted to learn more about the other side of it. Because when you do trauma surgery, you're kind of like a generalist. And so you manage the critically ill, but there's aspects of the management where it's like you don't really take part of. For example, someone that comes in with a head trauma that expanding subdural that needs to go to the OR. Like we don't go to the OR for that. We stabilize them and say, okay, they can go to the OR. And I don't see that. Or like if someone comes in with an open tib fracture or a femur fracture, like I don't see that. Like the orthopedic will bring them in once the patient is deemed stable from our perspective. And so that's why I wanted to go to that other side as well too. At NYU, that's where I learned neurosurgery, mostly spine surgery. While I was doing that, I was also doing primary care as well too. So that's what I meant by like the versatility of being a PA. I get to also apply some of the knowledge that I know in general surgery to the primary care world, and then from the primary care world to the general surgery world. So it's like I like that. That's what I like about this profession. And then afterwards, during my neurosurgery days, I went to business school because I wanted to go into leadership. I want to go into management. Like I like taking care of patients, but I want to take care of more people in more of a policy sense. And so that's why I went to business school, went to Quinnipiac for healthcare administration. Afterwards, I decided to do a pilot with Kaipa, which is house call. And then from there, that's kind of when I faded into Kaipa, got a position there and became the clinical director. And so over there now, I oversee the house call program. I help them build and establish a primary care clinic, a cardiology clinic, and then there's all the special projects that I'm working on as well too. So besides house call, there's other initiatives that I work on for Kaipa.
What drew you to your work focusing on population health and healthcare policy for the AAPI community specifically?
Well, I mean, as I mentioned earlier, that I did some primary care work in the community, and I've always there's always an affinity of helping out my AAPI community as well too, and so therefore, you know, going into Kaipa was a no-brainer for me, because if we are helping the doctors on helping in terms of the administrative side and also on the population health side, because it's not just about the administration where we help negotiate contracts on behalf of doctor to get better reimbursements. That's important as well too, because without better reimbursements, the independent doctors cannot sustain themselves in a practice, especially in a world right now where rising expenses all over the place. So that's very important. Otherwise, they can't sustain a business. Um, the other aspect of it is not only managing the doc but also managing their patients. So let's just say we have like 1,200 doctors. That 1,200 doctors, all their patients kind of is part of our oversight as well too. So we have to look at that and manage them in a way where it's like, okay, this bucket of patient with diabetes, what are the programs that we can have to improve the diabetic population? Either when I say improvement, either the score is lower or they avoid hospitalization. That's really not that's a one example. Another better example would be like the congestive heart failure. Those patients that are very sensitive to what's called volume overload. So a lot of times is, they go to the hospital because they're fluid overloaded in their lungs, they can't breathe, therefore they go to the hospital. So how do we take that population? How do we monitor them? And how do we identify an issue, for example, like the whole fluid overload, before actually going to the hospital? So like, what are the programs we could establish to avoid that? And by doing that, you can improve the patient's outcome. At the same time, you improve like the cost of care.
Could you tell me a little bit as well about your experience working in healthcare during the pandemic?
I mean, it was nerve wracking. I mean, when the ironic thing is, I just came back from Taiwan. I think about a week or 2 weeks before we actually closed the border. So if our trip was extended out of nowhere, I would have been like trapped in another country for God knows how long. So that would have been a different, an alternate reality, let's just say. Um, Coming back, it wasn't that nerve wracking until like later on, when we start seeing the numbers rise, and then everyone, even people that I know, were getting sick, and then that's like, and the next thing you know, like, going to Manhattan, there's no traffic. It was a dead zone. Yeah, it just, you could see the how the entire pandemic playing out, almost like a very scary movie, a very surreal experience, where they're just like the streets are abandoned. Like going to Chinatown, which both 8th Avenue and Manhattan Chinatown, it's like normally like vibrant, full of people. You can't even walk the streets. You have to walk on the road. And next thing you know, like there's no one there, no one out there. So it's very eerie. Um, that, and at the same time, it's like it was getting to a point, because I still have a lot of colleagues in the hospital, and I think I was around 2 years out from working in the hospital, and so like I was living through their experience, through what they're telling me. At the same time, I was thinking, okay, wow, being in the administrative side, there's a perk side, and then there's the downside, where it's like, okay, what can I do to help? So when we're talking about this, like with the board, and we want to try to contribute in a way where we want to offload the hospital system. One of the biggest thing at that time was people questioned whether they had, or people were scared. They didn't know whether they had COVID. Um, and at the same time, like even the doctor's office were all like closed down. So which means that if they're scared, they don't know they have COVID. I think the reptilian brain would be like, oh, let's go to the hospital. Let's seek care. And even if they don't have it, by the time they got there, they probably catch it from there. So we're like, okay, how do we help with that situation? Um, we should start, thinking about testing. And I think testing is very important. And how do we do it in a manner where it's safe, and at the same time, when there's a lot of shortage in terms of equipment, like there's no gowns, there's like mask, N95, those are very valuable at that time. So we're like saying, all right, how do we help with this situation? And then the board came out, oh, we have to do mobile testing. We'll think about like a retrofitted ambulance, and then parked in the community, and then you'll have the community doctors send in the referral, and then they go to this one place, which is the mobile truck, and then they just get swabbed. And so, like, the moment I heard about this idea, I'm like, I guess we could do that. And then at the same time, I'm like thinking, okay, why are we recreating why are we recreating this? Why don't we just see what other people are doing? So I was looking at South Korea. They actually had this telephone booth model. So we literally built a prototype with just PCB pipes, and then we had one of those makeshift like plastic. It kind of almost like reminds you of a greenhouse. Now that I think about it, we're like, oh, why don't we do something like this? And then we'll have like socket of gloves where it's sealed in, and somehow we'll have the testing kit outside, and then patients will just register on the van, and then they'll come to the telephone booth where they get swabbed, and then they just leave. And then after each session, we'll just like bleach the area so that everything's sterilized. And at that time, the only thing we knew was, okay, as long as it's a diluted portion of bleach, it'll just kill everything. So that's one of the things that we were concerned about. It's like, oh, how do we sterilize this so that people are comfortable with this setup? And so we did that. We didn't use that for too long because the process took too long from end to end. So what we did was we partnered with several organizations, like Fidelis was one of them, Empire Blue Cross Blue Shield, and they were, at that time they weren't out in the field, so they were fortunate. We were fortunate enough to have them help with providing us their vehicles. So when they provide us with their vehicles, I was looking at their RV. It's like one of the RV. They also provided their driver, and they provided gas and all that, which is very 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 nice of them. And I looked at their RV. There's the side door, and then inside the side door, there's like a second door that's almost like when you have a house, I don't know, it's like a screen door. So I looked at the screen door, and I'm like, okay, the screen door comes in like two different glass partitions that are netted. So I'm like, okay, why don't we do this? Why don't we take those netting out and replace it with a plexiglass, and then on the bottom portion of it, why don't we put like a kangaroo box where it's when we get the specimen, we put the specimen from inside, and then external you could take it out, so there's no touching with the patient. And then why don't we also hang like a bleach spot, like a small bleach bottle outside too at the same time. So after we're done swabbing, we put it back into the kangaroo box, and then we have like a biohazard bag. We flip it, we invert it, we just take it out, close it, and then sanitation wipe, and then we're done. And then we just clean the outside. And then we're like, oh, we could do that. And that definitely sped up the process a lot faster. And that also not only sped up the process a lot faster, we didn't have to use a lot of PPEs. We still wore a mask inside, but we didn't have to like go crazy and be like N95 plus a mask. And we didn't need to fully gown up and stuff like that. So that worked. And it worked pretty well to a point where it's like, okay, now that we have 3 vehicles, all I have to do is recruit enough PAs to help with the process. And so after like, I think a week or 2 weeks, we're like, okay, let's roll this out. We went to Elmhurst, we went to Flushing, went to Manhattan, Chinatown, went to Brooklyn, anywhere that it's like, I would like to say in need population where like there's not a lot of a lot of resource for at least for the AAPI community. And so I would like to say we were the first one out there during the peak of the pandemic, which was one scary looking back because like I can laugh about it now, but like God forbid we didn't know because at that time it's like there's a lot of unknown. So imagine like we all got sick and God forbid we all got sick. That would have been a different scenario, and we wouldn't be doing this interview, right? Um, so it
What was it like going into those communities?
it was almost what I was mentioning earlier. It's like a dead zone until we announced that we were doing the testing, and then there was a lot of people lining up. In the beginning, we wanted to be a controlled fashion. We're like, okay, within our network of doctors, if you have people that require testing, then send them over, and then we have the system going too, where they fax their information over, and then we validate it, and then afterwards we'll put an appointment, and then later on we're just like just bring them. So it's like everything happened in like a methodical fashion, because again, we don't want to. Our concern is that we could not control the crowd. That is always my concern. Like I don't want a mass pandemonia, when our vans are out there. So that's yeah.
How did Kuiper also assist in the vaccination effort?
So the vaccine effort came about, I would like to say late October of last year, or probably earlier. We had issues in terms of securing the vaccines. Uh, One, because I think there was such high demand, and I think there were only some selected few who had access to it. Somehow, we don't know how. The way we had access to it is through two methods. One way was through applying through the city program, which is through the citywide immunization registry program, and apply through the Moderna. We did the Moderna vaccine first. And then the second route was through the state. The governor's office have allocated some Pfizer vaccines from the Javits Center. So again, very fortunate to have like strong partners to help out to procure that. Because again, access is very rare, and so it's for us to have the fortunate to get these vaccines so that we can provide for the community was big, especially for our seniors. That was our main focus, like seniors. And in the beginning, especially with the Moderna vaccine, it was we just had to plan meticulously, understanding the insert, reading like how the vaccine works. In the beginning, we were more like sensitive with how the vials were. We're like making sure all the temperatures are at the ideal state. And then because I think at that time they were slowly like telling us like bits and pieces of new information that came on board that made it like less restricting. But in the beginning, it was very restrictive in terms of who got the vaccines, how to store the vaccines, all the regulatory, which it's understandable. But at the same time, it made it very difficult for small practice to operate, because it's not only that they have to procure the vaccine, they have to maintain the vaccines. Every day they have to check up on the temperature of it, which we should be doing anyway to begin with as part of the standard protocol. And then God forbid, like let's say power goes down and then your temperature goes up, and you're like, the vaccine's garbage now. So those there's a lot of concerns over there as well too, in terms of especially in the beginning. But I think at least our Moderna, actually both our vaccines rolled out pretty well, despite all the regulations. I think the biggest hurdle was like the logistics between like who gets it, and not only that, who gets it, and then like when they started opening these other restrictions, oh, you have comorbidities, oh, if you have a you have comorbidities, and if you, or if later on you work in the city, and then you have to validate whether, okay, A, do you live in, are you a New York City resident? If not, okay, what's your other qualifier? Okay, you work in New York City. Okay, then do you have a work certificate or an ID card or something? And then a second will be like, oh, those with comorbid conditions, like those that do not hit the 65 and older. Like, okay, then can you validate that? So, and then I have to make sure that we have that data as well too. So it's like, God forbid, the Department of Health come and like start doing an audit. Like, you don't have this documentation. What are you guys doing? I'm like, but we have it. But that's like kind of the stresses that came about with the vaccine, especially early on. Now it's like, okay, everyone gets it. They don't care. Well, everyone that are in a certain that fits the profile. I think there's still age 12 and above. I don't know what the current guidelines are below 12. But anyway, so yeah, so that made it challenging.
How did the community respond to both the testing and vaccination operations?
So we didn't have a lot. We didn't have a lot of the patients that were like questioning the vaccines. I mean, those that are at the site would be like they wanted one anyway. But the challenge is like those that came to our site. We did have patients that were like, oh, is it the Johnson and Johnson one, or is this the Moderna one, or is it the Pfizer one? And it's like, it's not a shop, it's not a supermarket. You can only have what we have. Like I can't like go storing Johnson and Johnson, Pfizer. Like those are different type of storage system, and it's also a different type of vaccine as well too. Well, Pfizer and Moderna are the same, but the Johnson and Johnson is a different type of vaccine. So we had those, but we didn't have any like those anti-vaxxers that, I mean, we didn't have protests, thank God. We didn't have people that with signs up saying anti-vaccine. Thank God we didn't have that as well too. So.
Did you, in your communication with the community, was there an element of kind of trying to support and spread the message to, get vaccinated, get tested, and how effective was that, and what were the challenges you faced?
I mean, every time we had a vaccination center that were launched, we would all the media, Singdao, World Journal, all the Chinese relevant media outlets, even the non-Chinese ones, would come check out the center, and then from there we would like encourage through the media outlets. It's not only through there, but also through like our social media, but honestly, like with the 65 and above generation, it's mostly either newspaper, word of mouth, and WeChat. Those are the only three. And I think WeChat was the one that, from my understanding, has been giving a little mixed messages. So I have no control over that, and it's WeChat is not really a reputable news source, if you ask me, right? So yeah, those are our outlets, and so the education piece is strictly through the media, and if the patients are there and ask questions, then we'll answer them to address that any vaccine hesitancy, any inaccuracy with what they're reading with the vaccines.
Yeah, so what worked well, and what did you learn as you implemented the testing and vaccination initiatives?
What worked well? I think I don't know. I don't really know how to answer that. I mean, like I think the entire process. I don't want to say we thought everything through in terms of both the vaccines and the testing. We thought about it from a lot of various different angles in terms of how we can execute it and make it successful. And I think we've done as good of as best that we could have done in terms of like executing both projects, and they're both both different scale. It's like one year we were doing testing, which is like, okay, looking back at this point, I'm like, testing was pretty a piece of cake. But looking at vaccines where I'm injecting substance into people with an FDA emergency use authorization, a certification only, I mean, the risk is definitely like when you compare, it's not apples to apples comparison. So the thought process was probably a lot higher with the vaccines, just like, but I think, working with the team that I have, um, I think we did a fairly good job in terms of making sure that, this, considering the safety, logistics, the messaging, and really focusing on like the throughput as well too, because we want to make sure people just get in and out and just go, in and out and just go, just so that we can avoid any like outbreaks in the center itself. So enforcing people to wear masks, making sure they have appointments. Those are really critical because, like, again, what I mentioned about earlier with the MRTC, we don't want people clustered in one area. There are some times it did happen. We had to break, up the crowds and stuff like that. But we try the best as we can in terms of avoiding that situation.
During the pandemic, Kuiper was responding to the Asian hate crimes and racism and events that were being reported across the country. How did you personally grapple with your passion to help people through the healthcare sector while also internalizing the maybe traumatic events that you were seeing in the community?
It's very unfortunate. It's some of the heinous acts against Asian Americans. Um, you know, and it's a component of a lot of different things. Some of the rhetorics that were going out politically, and then portion of it, I would say it's also due to like mental health, behavioral health. For me, you know, I think of healthcare, I have to be unbiased, and even if they hate me, I'd still have to take care of them. It's not like I haven't done that in trauma surgery before. Like in trauma, you see all types of people, and so even if they have a negative feeling towards me, I still have to do my job, right? So,
Yeah, and what were you feeling personally during that time?
well, I mean, I wasn't as anxious, but there is aspect of me that was hyper vigilant, especially when I was going to work. So I would wear my headsets and I would look at my phone. Now it's like I look around. I'm always on a ready. Um, so I just like I look around to see who's around me, and then um, from there I just like just make sure like nothing happens. And I made sure I drive my wife to work a lot just because she commutes to via taking a train, and so like I'm making sure like she's safe as well too. So and I pick her up, drive her and pick her up during, especially during the time when the hate crime was rising tremendously. Um, I would like to say it kind of feels like things are tampering down now, please. um, but yeah, just more hyper vigilant, and more aware of my scenario, my surroundings, and take off my iPods, not look at the phone, focus on surroundings.
Where do you see kind of the connection between maybe inequalities in the community in terms of healthcare?
There's definitely a barrier to access of healthcare due to like language barriers, which is why like during when we're promoting the vaccines and the mobile testing, the flyer has to be in both languages so people understand. And even if it's like in Chinese, like I had to like ask my relatives to read it to see like if they understood what it means, because just like in English, like you can interpret it so many different ways. And even if you provide instructions, like they normally either they overlook the instructions or they just go straight to let me just talk to someone. So one of those. And So yeah, so there is a barrier in healthcare, especially in the in the Chinese community. Um, a large part is due to language.
What are your hopes for the future of healthcare and access to healthcare for the AAPI community?
Besides having better access to care, besides having all the hospitals have like translators, and so that they are not only translators but also like the understanding of how the culture is, so that it takes the fear out of Asian Americans going to certain hospitals. For example, I have a relative recently was hospitalized, and he didn't understand exactly like what's going on. So I have obviously I show up. It's a little different because I can get the nurse, I'll get the doctor, and at the same time I speak the language in terms of the medical lingo, so I understand exactly what's going on, and then translate it back to my uncle. And then, but again, if I was not in the equation, he would be like confused, scared, and I probably a lot of Asian Americans are feeling that way, or Asian immigrants especially. Even if let's say even if you do have a relative that speaks the language, there's still no layer of understanding of like the medical terminology and all, and that can still cause confusion as well too. So it's not just about like having someone that is a medical professional or having someone that is just fluent in English. It's even if they're fluent in English, we have to figure out in the layman's term how to make them understand. Because when I'm saying things to other medical colleagues, people that are not in the medical field would not understand. And so you know,
Thank you so much for speaking with me today and sharing your experience during the pandemic. Your insight about healthcare for the AAPI community is so important to document. So thank you for your contribution to MOCA, and also for taking the time to discuss your role as the clinical director for the Chinese American Independent Practitioner Association.
thank you, Megan, for having me. Thank you, Mocha, for inviting me for this.